1, 2,
and rabies, 70-year-old female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
So you're staring down a literal mountain of obstetric nursing textbooks.
Yay.
And you're probably trying to figure out what will actually save a life and save your grade when the pressure is suddenly on.
Oh, yeah. The sheer volume of information is just, it's completely overwhelming.
It really is. And worse, a lot of it feels, I don't know, totally disconnected when you're just reading endless bullet points.
Exactly. Which is why, in this deep dive, we are aggressively applying the Pareto principle to your study plan.
The 80-20 rule.
You got it. Our mission today is to extract that critical 20% of high-yield facts, safety priorities, and clinical patterns that will honestly give you 80% of the exam value. We are bypassing the fluff.
I love that. So basically treating you as the ultimate clinical mentor today.
Right. Think of me as your coach. We're going to focus intensely on the underlying pathophysiology, the actual why and how behind these symptoms, so you can spot the classic exam traps and prioritize your actions instantly.
Okay, let's put that to the test with preterm labor. The baseline definition is pretty straightforward, I think. Regular uterine contractions causing cervical change before 37 weeks.
Spot on. The cervical change is the definitive proof there.
But diagnosing ruptured membranes early, like PPROM, that seems a lot trickier. Say a patient comes into triage at like 33 weeks and says she felt a gush of fluid.
Right, because we obviously need proof that it's actually amniotic fluid and not just, vaginal secretions or urine.
Yeah, exactly.
So the clinical environment relies on two highly tested diagnostics here. First is the nitrazine test. You have to think about the chemical environment of the vagina, which is naturally acidic to prevent infection.
Okay, that makes sense.
Amniotic fluid, however, is basic. It usually sits at a pH between 7.1 and 7.3. So when you introduce a nitrazine swab to that basic fluid, it instantly turns blue.
Ah, okay. Blue means basic. Basic means amniotic fluid. That's a great memory anchor.
Yeah, and the second diagnostic is the Fern test. If you swab that fluid, place it on a microscope slide, and just allow it to dry.
It makes a Fern pattern.
Exactly. The high estrogen and sodium chloride content in the fluid causes it to crystallize. Under the microscope, it forms this highly distinct palm leaf or fern-like pattern.
Okay, so if the water is broken, we lose that sterile protective barrier. My mind instantly jumps to Chorioamnionitis. Infection, basically.
Right, which is a huge priority. But there is a massive diagnostic trap here when looking at lab values.
Is it the white blood cell count? Because I noticed a normal pregnancy WBC can hover around 15,000, right?
It can. And throw in the physical stress of active labor or the administration of corticosteroids and demargination occurs.
Meaning the white count jumps up.
Yeah, the white count can organically spike to 30,000 without any infection present at all.
Wow, 30,000. So relying solely on leukocytosis to diagnose an infection in a laboring patient
will absolutely cause you to fail the exam question and worse, mismanage the patient. You must look for the systemic inflammatory response.
So what are we looking for specifically?
To confirm suspected chorioamnionitis, you pair that elevated white count with a maternal fever over 100.4 degrees Fahrenheit, a really tender, irritable uterus, foul-smelling amniotic fluid, and critically, fetal tachycardia.
Okay, fetal tachycardia makes perfect physiological sense there. As the mom's temp rises, her metabolic rate increases, and the fetal heart rate just shoots up to compensate.
Exactly. It acts as an early warning siren.
Got it. Okay, let's assume we confirm preterm labor, but rule out infection. The provider orders tocolytics to halt the contractions. Giving a tocolytic just seems, I don't know, kind of counterintuitive in a way.
How so?
Well, we're administering medications powerful enough to completely paralyze a contracting uterus. The systemic side effects for the mother have to be pretty intense, right?
They're profound. Which is why tocolytics are so heavily emphasized on nursing exams. You really need to understand the mechanism of action for each one to anticipate the danger.
Okay, let's take terbutaline.
Right. Terbutaline is actually a potent bronchodilator. used off-label to relax uterine smooth muscle. It achieves this by stimulating beta-adrenergic receptors.
Oh, wow. So you were essentially triggering a localized fight-or-flight response.
You are. You're forcing the mother's cardiovascular system into overdrive just to relax her uterus.
That sounds dangerous. So what's the priority nursing action?
Before administering terbutaline, always auscultate the maternal heart rate. Always. If her heart rate is greater than 120 beats per minute, you withhold the medication and notify the provider.
Hold for HR over 120. Got it.
And you also must listen to her lung sounds carefully. The altered hydrostatic pressure carries a very high risk of drug-induced pulmonary edema.
Terbutaline sounds incredibly harsh on the maternal system. I mean, is there a pharmacological way to relax the uterine muscle without sending her heart rate completely through the roof?
Yeah, there is. We target the muscle's dependency on calcium using nifedipine.
Okay, nifedipine, that's a calcium channel blocker, right?
Exactly. It prevents calcium ions from crossing the cell membrane into the myometrium. It basically starves the muscle of the electrolyte it needs to contract.
Right, but what's the systemic catch there?
The physiological consequence is that it also relaxes the smooth muscle in the maternal vasculature. The blood vessels dilate.
Oh, so blood pressure drops.
Yep. Your priority assessment shifts entirely to monitoring for severe maternal hypotension, dizziness, and you have to establish fall precautions.
Okay, that brings us to the heaviest hitter in the obstetric pharmacy, magnesium sulfate.
Oh, the exam favorite.
Right. It's used for tocolysis,
Yeah.
but also heavily tested for its role in fetal neuroprotection, like preventing cerebral palsy in imminent preterm births.
Very true.
The memory anchor I use for mag sulfate is that it acts as a massive central nervous system depressant. It just drags every bodily function down. But what is actually happening at the cellular level?
Well, magnesium acts as a calcium antagonist at the neuromuscular junction. It literally blocks the release of acetylcholine from the nerve terminals.
And without acetylcholine, the signal for the muscle to contract never arrives.
Exactly. That mechanism is exactly why you see the classic signs of magnesium toxicity. It's highly testable.
Okay, what do we look for?
The deep tendon reflexes, or DTRs, disappear first because the neuromuscular transmission is blocked.
Right.
Then the respiratory muscles weaken, causing the respiratory rate to drop below 12 breaths per minute. Urine output will also drop below 30 milliliters an hour because the kidneys struggle to excrete the magnesium.
Which just compounds the toxicity even more.
Exactly. It's a dangerous cycle.
So if my patient loses her deep tendon reflexes, the magnesium is essentially sterilizing her.
Yeah.
I would immediately stop the infusion.
Right. Immediately.
And the absolute priority safety action has to be keeping the physiological antidote at the bedside. That's calcium gluconate, right?
Yes. Keep calcium gluconate readily available to flood those receptors with calcium and restore muscle function.
Okay, so the overarching goal of all this pharmacological breaking is really just to buy us, what, a 48-hour window?
Yeah, pretty much. We need that time to administer beta-methazone.
The corticosteroid.
Right. It's an intramuscular shot given to the mother that crosses the placental barrier. It stimulates the type 2 pneumocytes in the fetal lungs to rapidly synthesize and release surfactant.
Which lowers surface tension in the alveoli and prevents respiratory distress syndrome when the baby is born.
Exactly. And remember, it requires 2 doses administered 24 hours apart.
Okay, but what if the tocolytics fail? Or what if the patient arrives at full term? I imagine our entire focus shifts to the electronic fetal monitor.
It absolutely does. We have to gauge how the baby is tolerating the hypoxic stress of uterine contractions.
I always like to think of fetal heart rate variability as a constant tug of war between the baby's sympathetic nervous system, like the gas pedal, and the parasympathetic nervous system, the brake.
That is a brilliant analogy. That tug of war demonstrates a healthy, intact, and well-oxygenated fetal brain.
And the baseline should sit between 110 and 160 beats per minute, right?
Right, but we want to see moderate variability on top of that baseline. Those constant beat-to-beat fluctuations mean the neurological pathways are actively responding to the environment.
So minimal or absent variability, like a flat line on the monitor.
Means the baby has dropped the rope entirely. That's usually due to severe hypoxia, profound acidosis, or maternal central nervous system depressants.
Okay, so that brings us to decelerations. These are the ultimate exam trap because, they all just look like dips on a screen, but their underlying causes are totally different.
Very different.
Let's start with early decelerations. They seem the most benign. As the mom's contraction builds, the baby's head gets compressed in the birth canal.
Exactly. That physical pressure stimulates the fetal vagus nerve, causing the heart rate to dip in perfect tandem with the contraction.
So the tracing creates a perfect mirror image.
Yep. The nadir of the deceleration aligns exactly with the peak of the contraction. It's an entirely expected physiological response to fetal descent. Your only nursing action is to document the finding and continue monitoring.
Simple enough. But variable decelerations paint a much more chaotic picture. They look like sharp, jagged V's or W's on the tracing, right?
Yeah, and they drop precipitously regardless of the contraction cycle.
What's the mechanism behind that sharp V shape?
It's fascinating, actually. Variable decelerations are caused by umbilical cord compression. The umbilical vein is thin-walled, so it collapses first under pressure.
Which drops the baby's venous return.
Right. Fetal blood pressure drops, the sympathetic nervous system panics and briefly spikes the heart rate. But a moment later, the thick-walled umbilical arteries get squashed.
Oh, so suddenly fetal blood pressure shoots way up.
Exactly, triggering the baroreceptors to fire a massive vagal response, slamming the brakes on the heart rate. That sequence creates the dramatic, jagged drop on the monitor.
That makes so much sense. But what if the heart rate drops gradually, and it doesn't even begin to fall until after the maternal contraction has reached its absolute peak? Like, it recovers long after the uterus is totally relaxed.
That is highly concerning. Those are late decelerations, and they indicate uteroplacental insufficiency.
Meaning the placenta is failing.
Basically, the placenta functions as the fetal lungs. During the peak of a contraction, maternal blood flow to the inner villus space is momentarily cut off. A healthy placenta has enough oxygen reserve to carry the baby through that squeeze.
And a failing placenta does not.
Right. The baby becomes transiently hypoxic, the chemoreceptors detect the falling oxygen tension, and the heart rate drops late in the cycle.
So the baby is essentially suffocating with every single contraction. We have to initiate intrauterine resuscitation immediately.
Yes, and the classic mnemonic is lion or fomi.
Let's break down the clinical logic of lying.
Right.
We stop the oxytocin or pitocin first.
Right, always. You have to eliminate the pharmacological stressor that is causing the contractions and restricting the blood flow.
Makes sense. Then we aggressively alter the hemodynamics. We reposition the mother to her left or right lateral side.
Exactly. This physically lifts the heavy gravid uterus off the inferior vena cava and the descending aorta. It instantly improves venous return to the maternal heart, which improves cardiac output to the placenta.
Okay, so stop, petition, reposition. Next, we open the IV wide to deliver an isotonic fluid bolus, right?
Yes, to maximize maternal blood volume.
And finally, we apply oxygen via a non-rebreather mask at 10 liters per minute.
Right, to hyperoxygenate whatever blood is actually reaching the inner villus space. Stop the stress, maximize flow, maximize oxygen.
Master that sequence because it applies to nearly every hypoxic fetal event. But those late decelerations can sometimes be the earliest warning sign of a catastrophic physical emergency too, right?
Oh, absolutely. Things like a prolapsed umbilical cord, a placental abruption, or a uterine rupture.
Let's analyze the prolapsed cord first. Say the mother's water breaks, usually before the fetal head is firmly engaged in the pelvis.
Right, so the sudden gush of amniotic fluid washes the umbilical cord down past the fetal presenting part and right into the birth canal.
And the moment the baby's head descends, it crushes its own lifeline against the mother's pelvis. We'd see severe, prolonged fetal bradycardia on the monitor.
Exactly. So you perform a sterile vaginal exam and actually feel the pulsating cord in the vault.
Now, the instinct for a lot of students might be to try and gently push the cord back up into the uterus to protect it.
And doing so will almost certainly kill the fetus.
Wait, really? You don't push it back?
Never, ever try to stuff it back in. Touching the cord causes severe vasospasm. The umbilical arteries will clamp shut in response to the physical manipulation, completely cutting off fetal circulation.
Wow. Okay, so if we can't touch the cord, the priority action must be manipulating the baby instead.
Exactly. You use a sterile gloved hand to reach inside the vagina, grasp the fetal presenting part, and physically lift it up and off the umbilical cord.
So you basically become the mechanical scaffold keeping that airway open.
Yes. And you do not remove your hand under any circumstances until the baby is surgically delivered via emergent C-section. You also instruct the team to place the mother in a knee chest position.
To use gravity to pull the fetus back toward the diaphragm and away from the pelvis.
Exactly.
Contrast that mechanical obstruction with our major hemorrhagic emergencies, like placental abruption versus uterine rupture.
Highly tested comparison.
In an abruption, the placenta prematurely tears away from the inner wall of the uterus. And the key detail is that the bleeding is often concealed behind the placenta. Right.
Yes, blood is forcefully pumped into that confined space under arterial pressure. That high-pressure accumulation of blood infiltrates the uterine muscle fibers.
Which causes the hallmark presentation.
Right. Dark red vaginal bleeding paired with a rigid board-like abdomen. The uterus becomes exquisitely tender and hypertonic because it's distended by a massive pressurized hematoma.
Uterine rupture, on the other hand, takes that pressure to its absolute breaking point.
Yeah. The actual muscle of the uterus tears entirely open, most commonly along the weakened scar line of a previous C-section.
So how do we distinguish them on an exam?
The diagnostic differences are stark.
Yep.
A rupture involves a sudden, sharp tearing pain. On the monitor, you will see a complete and sudden cessation of uterine contractions because the torn muscle can no longer functionally contract.
And critically, you observe a sudden loss of fetal station.
Exactly. The baby was descending, the muscle gives way, and the fetus essentially slips backward, floating up into the mother's abdominal cavity.
Terrifying. Both abruption and rupture mandate a massive hemorrhage protocol and an emergent C-section. But there's one emergency where a C-section is no longer an option. Shoulder dystocia.
Ah, yes. The fetal head delivers, but the anterior shoulder becomes wedged tight behind the maternal symphysis pubis.
And the cardinal warning sign is the turtle sign, right? The head emerges, but because the shoulder is anchored behind the bone, the head is tightly retracted back against the perineum.
Yes. Now, my question for you. What's the immediate instinct when a baby is physically stuck in the birth canal like that?
Honestly, my instinct would be to apply downward force on the top of the mother's belly, the fundus, to try and just force the baby through the pelvis.
And that is a catastrophic nursing error.
Oh, wow. Really?
Yes. Never apply fundal pressure during a shoulder dystocia. Pushing on the fundus only impacts the anterior shoulder harder into the pubic bone.
Ah, so it makes it worse.
Much worse. It widens the fetal biacromial diameter and can cause a severe brachial plexus injury to the baby or even exert enough shear force to rupture the mother's uterus.
Okay, no fundal pressure, so we had to change the geometry of the pelvis itself.
Exactly. We utilize the McRoberts maneuver. You pull the mother's legs sharply back and flex them flat against her abdomen. This flattens the sacrum and significantly opens the angle of the pelvic outlet.
And simultaneously, another nurse applies suprapubic pressure, right?
Yes. You press firmly straight down, directly over the mother's pubic bone. The goal is not to push the baby out, but to physically collapse the baby's shoulder downward so it can slip under the bony obstruction.
Got it. Now, even if we avoid a catastrophic emergency like a rupture or a dystocia, the final moments of pushing carry their own subtle risks. The baby is right at the finish line, but the stress takes a toll.
It really does.
And that stress often manifests physiologically before the baby is even delivered. Which brings us to meconium-stained amniotic fluid.
Right. We all know meconium is the fetal first stool. But the clinical insight lies in why it's passed in utero.
Is it hypoxia?
Yep. If the fetus experiences severe, prolonged hypoxia, the vagus nerve is heavily stimulated. This triggers increased intestinal peristalsis and relaxation of the fetal anal sphincter.
So they release meconium into the amniotic fluid, turning it a dark green, like pea soup color.
Exactly. And the ultimate danger is meconium aspiration syndrome. If the baby gasps during delivery and pulls that thick, tar-like substance into their lungs, it causes severe mechanical airway obstruction and chemical pneumonitis.
Which is terrifying.
Yeah.
Now, the historical protocol was to deeply suction the airway of every single meconium-stained baby the moment the head was delivered.
And evidence-based practice has completely reversed that protocol, which makes it a major exam trap.
Oh, we don't suction everyone anymore.
We do not. Deep suctioning stimulates the vagus nerve in the newborn, which can actually induce profound bradycardia.
Oh, wow. Okay. So what do we do?
If the baby is born vigorous, with strong muscle tone and a loud cry, their airway is clear. You simply place them skin to skin and wipe their mouth.
Only intervening if they're depressed.
Right. You only bring them to the warmer for specialized endotracheal suctioning if the newborn is depressed, floppy, or apneic.
Yeah.
We rely on the baby's own physiological vigor.
Okay, but what if the mother's physiological vigor runs out? Say, maternal exhaustion sets in during the second stage of labor, or the fetal heart rate shows terminal bradycardia.
Then the provider may utilize an operative vaginal birth using a vacuum extractor or forceps.
And the criteria for that are pretty non-negotiable, right?
Totally non-negotiable. The cervix must be 100% dilated. The amniotic membranes must be ruptured.
And the baby's position.
Most importantly, the fetal head must be fully engaged in the pelvis, sitting at a +2 station or lower. You cannot reach high up into the pelvic inlet with instruments.
That makes sense. Applying a vacuum cup to the fetal scalp and applying traction carries significant trauma risks, obviously.
Yeah.
We have to monitor the newborn closely for cephalohematoma.
Yes. A cephalohematoma is a localized collection of blood between the newborn skull bone and its periosteum. It's caused by the shearing force of the vacuum.
And because it's confined beneath the periosteum, the swelling will never cross the cranial suture lines, right?
Perfect. That's a key assessment finding.
A localized bleed sounds manageable, but the downstream physiological effect is severe. As that trapped collection of red blood cells breaks down, it releases massive amounts of unconjugated bilirubin.
Right, and the immature newborn liver simply cannot process the sudden metabolic load.
So that dramatically increases the risk of severe pathological newborn jaundice or hyperbilirubinemia.
Exactly. The cephalohematoma to jaundice pipeline is a vital clinical connection to make for your exams.
That ability to connect the mechanical action to the systemic consequence, that's exactly what we're aiming for today. We've covered the most critical paradigms in obstetric nursing.
We have.
To solidify this, let's distill all this pathophysiology into the 5 absolute highest yield takeaways for the exams.
Let's do it.
All right, takeaway number 1.
Magnesium sulfate is a central nervous system depressant that blocks neuromuscular transmission. Toxicity presents as absent deep tendon reflexes and severe respiratory depression. And the physiological antidote is calcium gluconate.
Perfect. Takeaway number 2.
Late decelerations indicate uteroplacental insufficiency and fetal hypoxia. Execute intrauterine resuscitation immediately.
That's the lion mnemonic.
Yes. Stop the oxytocin to remove the stressor. Position the patient laterally to improve cardiac output. Administer an IV fluid bolus and apply oxygen.
Okay, takeaway number 3.
In the event of a prolapsed umbilical cord, never attempt to push the cord back inside as this causes severe vasospasm. Use a sterile gloved hand to elevate the fetal presenting part off the cord to manually restore blood flow.
Takeaway number 4.
Placental abruption involves pressurized bleeding confined within the uterus, presenting with a board-like rigid abdomen. Uterine rupture is a catastrophic muscle tear, presenting with a sudden loss of contractions and a sudden loss of fetal station.
And finally, takeaway number 5.
Never apply fundal pressure during a shoulder dystocia. It will impact the shoulder further. Utilize the McRoberts maneuver to open the pelvis and apply direct suprapubic pressure to collapse the fetal shoulder diameter.
Master those 5 principles and you'll navigate the hardest questions on your exam with confidence.
Absolutely. But as your clinical mentor, I want to leave you with one final crucial piece of real-world judgment.
Let's hear it.
Algorithms, pathophysiological pathways, and mnemonics, they are incredibly powerful tools. They provide a vital framework for safety. However, the ultimate safety mechanism in any delivery room is your intuition and your direct observation.
That's so true.
You can become so hyper-focused on interpreting the subtle variability of the electronic fetal monitor that you forget to assess the diaphoresis, the breathing patterns, and the subtle behavioral changes of the mother laboring right in front of you.
Right. Never let the data on the screen blind you to the clinical reality of the patient in the bed.
Treat the patient, not just the monitor.
We started this deep dive talking about how obstetrics isn't black and white. It requires immense critical thinking and an understanding of the interconnected physiology of 2 patients at once.
It's a huge responsibility, but you're going to do great.
Thank you for joining us on this deep dive into obstetric nursing. Keep studying, trust your training, and we will see you next time.